Welcome back to the final webinar of the 14th Annual McKnight's Online Expo. I'm Jim Berkland, and I'll be your moderator. You're tuned in to the Clinical Care Track session, Understanding and Addressing COVID-19. We are, of course, grateful to have our distinguished presenters, as everyone on this line and associated with this session is vitally involved with coping with, preventing, and treating conditions brought on by the novel coronavirus at this historic time. In a few moments, we'll be hearing from our four presenters, Troy Brennan, Gary Irwin, Nancy Losman, and Derek Sturgill. But first, let's take care of some housekeeping matters. These slides are available for download. Access them via the Handouts tab. You can use the red icons on the bottom of your screen or the box on the left-hand side of the screen. Before we go any farther, I'll also remind you to visit our vendor booths following this session, but not during it, to comply with continuing education accreditation requirements. At this time, we would also like to thank Omnicare for sponsoring support for this timely session. If you are having any audio problems, please check your volume controls and personal machines as a first step. Also, we will be holding a Q&A segment near the end of the session. If you'd like to submit a question for discussion, click on the Question and Answers tab. We will start taking your questions now, in fact, and answer as many as we can at the end of the session. Finally, this educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards, that's NAB to most of us, and approved for 1 clock hour. However, to receive CE credit, you must receive a minimum of 50 minutes of the webinar during this live event. Once you have achieved 50 viewing minutes, a View Certificate button will display, and the required viewing duration will have a green checkbox. You can then view or save your certificate. You can track CE requirements through the Course Completion Tracker, which is accessed through the last icon in the area below the Open Webinar panel. Earned certificates can also be accessed from within the event navigation by clicking on Profile and My Certificate. If you provided a valid NAB ID number, which begins with the letter R's followed by 7 digits, and registered for the event with the exact name associated with your NAB ID, your credits will be reported to NAB on your behalf within 3 business days after the event. Well, we are in the midst of incredibly challenging times, both in our personal and professional lives, so we're very glad to hold this session to bring clarity to the issues and to offer advice for how best to handle this historic healthcare emergency. And with that, I'd like to bring in Gary Irwin to kick off today's presentation. Gary?
Thank you, Jim. My name is Gary Irwin. I lead Omnicare's clinical services, and I will be serving as the moderator of today's session. Also on the virtual podium with me are Dr. Troy Brennan, who is Executive Vice President as well as Chief Medical Officer of CVS Health. We have Nancy Losman, who is Omnicare's Chief Quality Officer. And we have Derek Sturgill, who leads Omnicare's Internal Operations Group. We will be going back and forth between the 4 of us addressing the agenda, which you're now looking at as the next slide. As you look at this, our goal is pretty straightforward. It is to talk a little bit about what is COVID-19 and what is unique about it, provide a little bit of a situational overview, and then we will move much more into tactics, operations, and best practices for what is really the purpose or the lens of this presentation, which is really the facility, the community, and the long-term care pharmacy relationship. And much of what we're going to be discussing really relates to the experiences that we have had to date and how we have begun to think in terms of best practices that others, including our client facilities, are able to undertake. The last thing that I really want to say is that this is a daily evolving situation. And I just want to stress that the guiding principle that we think about routinely is the safety of the facility and community patients and staff, as well as our own staff, to provide essential services. And sometimes that's easy and sometimes that's hard. And we'll try to address how we deal with that and what we think are really best practices to deal with that as we go along. So that's the agenda, that's the lens, and now we'll get started. So at this point in time, what I'd like to do is turn it over to Dr. Brennan, and he's going to take us through the next couple of slides around what is COVID-19 and kind of the situational public health view. So Dr. Brennan?
Thank you, Gary. Yes, it is a very trying time for all of us, and anybody in healthcare. In fact, it appears anybody in our country is affected by this today. But I would like to sort of stick to what are the kind of dry public health facts associated with the COVID-19 virus. It's a coronavirus, and like all viruses, we analyze it from the point of view of how much can it spread and how deadly is it. That's the way we look at viruses. And the notion of how much it can spread is a matter of a public health concept. It's called R0. It's basically how many people will one person infect, how many other people. There are some viruses like measles that are incredibly infectious. They have an R0 in the range of sort of 12 to 15. This virus is more infectious than the influenza virus, probably has an R0 of between 2 and 2.5. So spreading relatively rapidly, but not like some other viruses. And then the other question is, what's the mortality rate associated with it? The mortality rate with our regular influenza virus is probably less than 0.1%, maybe even slightly less than that. This virus we're not quite sure about because we don't have great denominator data on how many people have been infected. But at least in China and Korea, it looked like it was probably going to be somewhere between 0.5 and 1.0. Some of the data from Europe suggests it may be even deadlier than that, although it's, again, difficult to say because we don't have exact statistics on who has contracted the virus. So what we've got is a fairly deadly virus that is traveling relatively fast. 80% of people will have no clinical illness associated with this virus. They may get a little bit of a cough, maybe a headache, perhaps even a little bit of shortness of breath, a fever, but they probably wouldn't even seek medical attention, at least half of those, and the other half might give a call to their doctor. However, about 20% of people do get sick, 10% get quite sick, 5% end up in the hospital. And as I said, at this point, 1% are dying in the hospital. So it's a tale of two cities, and a lot of people are going to have very minor ailments, but especially people over the age of 70 are at great risk from this virus. So that would be how we look at it. It's not different than a lot of other viruses, except insofar as it's traveling relatively fast and it has this higher mortality rate. I'm finished there, Gary. Do you want to go on to the next slide? From a public health perspective, I think we have one more slide that we were going to look at, Gary. This has kind of our most recent 24-hour update that we are working on at CVS Health, and this is as of March 17th. What I can tell you is that the virus is spreading very quickly right now in Europe and in parts of the United States. In Washington, especially in New York, somewhat in Northern California, we're seeing rapid spread of the virus. And the same is true in much of Europe and Iran. But we're not seeing a lot of spread of the virus in some other countries. And so that's leading most people to think we're probably looking at one of two scenarios here. One is that this is not a seasonal virus. I'd say there's more people who believe it's not a seasonal virus, and that it will continue to spread. And the reason, the way in which we stop it when it's spreading like this is that basically we try to reduce that R0. And the way to reduce the R0 from the typical sort of 2.2 or 2.4 is that we engage in social distancing. And as a result of that, the virus spreads less. The people who have it stay away from other people, and we don't get to the levels of prevalence we might otherwise see. So essentially what we're doing is reducing the doubling time from what would be 5 to 6 days to double in terms of the number of people who have it, much greater out to 10 to 20. And so through that process, we attempt to reduce the amount of damage that the virus can do in the healthcare system. What we're especially worried about is if too many people get this at the same time, then the hospitals will be overwhelmed by people with respiratory distress. The other scenario is that it is a seasonal virus, and all of our influenza viruses, for instance, are seasonal, and at least in the northern hemisphere, they strikingly decrease in prevalence between March 15th and April 15th. If that were the case, then we'd see some fall off, but then we run into the problem that we may be seeing this as a seasonal virus that returns next fall with some sporadic cases kind of throughout the summer. So we're in uncharted territory. As you know, the authorities have put in place social distancing almost across the United States. That's the appropriate public health intervention to take at this point, and we're gathering data and trying to understand exactly what the impact of those approaches are going to be. So let me leave it there from a public health point of view and turn it back over to Gary.
Thank you, Troy. We're going to now move into a series of discussion points around tactics to prevent the spread of COVID-19. And again, our intent here is really to not focus on what Omnicare does or CVS does, but rather learnings that we have taken away from our own experiences, recognizing that all of you have learnings as well. But this is really kind of where we have made strides relative to how we're trying to do this. So the first part of this would be this slide on key aspects of a global response to a pandemic. And I think what we've established and probably have learned similar to you is that to effectively deal with this, there are multiple people that have to be involved. All of our colleagues and employees are affected, and so human resources is key. If you're lucky and you have an emergency response resource, or even if you have a single individual that's filling this role, it gives you an opportunity to have someone that is dedicated to almost serving as the liaison and bringing back information on an up-to-date basis. Everyone has operations that they have to deal with and keep going. There are clinical teams that are comprised of either your staff or, for example, our staff, and then there are legal issues that are playing a role in this as well. And so I think that probably a key aspect to this would be recognizing that all of these become important to mounting a response, as well as an interactivity among all of these groups in a way that brings some kind of calm and logic to what you're attempting to do. You may also go outside of your organization. So, for example, Omnicare is very lucky that we have a Dr. Troy Brennan who can provide us guidance and can provide us information around specific circumstances. And there are infectious disease experts that we have access to as well that provide advice and guidance under specific circumstances. So the kind of key takeaway from this slide would be everybody's engaged. There are aspects of this that touch all parts of our organization, and that having a coordinated working group that is meeting routinely, maybe 2 or 3 times a day, depending upon the size of your organization or the number of employees that you have or the number of patients that you take care of, becomes very important to giving a calm to the rest of the members of your group that may not be part of that, but also in driving your behavior and the materials and the information that you provide to your own employees. I'm now going to turn over to Nancy Losman to continue this part of the conversation.
Well, thank you, Dr. Irwin, and good afternoon, my fellow warriors in the COVID-19 mitigation battle. I'm going to address with you facilities who at this time have no evidence of COVID-19 within their facilities. first, I'd like to remind you that it is very important that a facility leader select a facility staff member with strong organizational and communication skills to be your point of contact for COVID-19 information and dissemination. Likewise, that designee should determine, if it hasn't already happened, the pharmacy's point of contact. Once that's understood, exchange cell phone numbers and add them to your contact list. Provide direct dial phone numbers and extension numbers to facilitate some crisp communication about your processes or your status. And while all of us have already limited visitors to our facilities to asymptomatic family members of hospice patients, facilities should also consider limiting unnecessary on-site visits from pharmacists, consultant pharmacists, pharmacy account managers, consultant nurses, and infusion nurses, unless the infusion nurse has a skill or a service that you cannot provide yourself. And following the CDC screening protocols for all staff before entering the facility, it is now, in these last few days, more likely that you are taking temperatures of your visitors. Please evaluate the technique of the person assigned to take the temperature. Do not ask the pharmacy representative or any other vendor to use a reusable thermometer. And monitor how your staff is cleaning electronic and temporal thermometers in between temperatures. Because a pharmacy driver may have many facility stops on their route, consider a single location for the pharmacy courier to deliver and for you to receive your medications. After all, you would not want your courier moving throughout the building from one nursing station to another after already being in several other facilities. When signing for pharmacy deliveries, as most nurses already do, use your own pen. If staff has to use an electronic device to sign for any delivery, even if it's from the UPS, use gloves or wipe the device with a disinfectant before signing and wash your hands afterwards. Place dirty infusion and enteral pumps in a bag or a disposable box before handing them back to the courier so that those dirty pumps do not contaminate other packages going to other facilities or coming back to the pharmacy. And finally, now is the time for you to evaluate the contents of your infusion emergency kit and other emergency medication supplies. For instance, while you may need hydration in some instances, you may also be able to avoid a discharge of a resident to an overtaxed hospital when you just have a bacterial infection that you may easily manage without transfer to the hospital or out of the facility, thereby eliminating further exposure of those very precious residents we care for. Gary?
Thank you, Nancy. So the next thing that we really confronted almost immediately was how we would deal with our facility or community clients regarding our own on-site clinical staff. And this became, if you will, one of the first interactions that actually began to occur that we began to learn about. So I think there's some key points that are really takeaways from this. First of all, in this relationship between who a provider for facility or the facility may actually be, communicating frequently and coordinating approach is a very key aspect to doing this. In many instances, that coordination is straightforward and it is aligned and it is easy to implement. Periodically, you will have tasks or services where there is a greater degree of difficulty in trying to coordinate what that approach is. And the communication and an open line of communication to address these very transparently with the guiding principle that I said a moment ago of safety to both facility, community, staff, and patients and employees does really take precedent over everything that's done. But I can't speak enough to communication is key, especially in a world where the facts are changing almost momentarily. The approach that we've taken and the approach that most of our clients, and as a matter of fact, almost all of our customers has taken, is that for the immediate future, limiting on-site visits to essential services that cannot be performed through remote activities. If I just speak for a moment about consultant pharmacists and field nurses or consultant nurses, I am a strong believer that their services are essential. They are there to provide safety to the residents that we serve. However, in a very short-term basis, with much of the technology that exists today, the services that are done can be done remotely. And that if you go back to communication above, and you are communicating findings and other kinds of clinical issues that you can determine remotely, you can conduct that job. You can perform those safety services and limit the exposure of everybody to each other. And every once in a while, you will run into something where it is not easy to do that. And that is where you then come down to some of the more stringent guidances relative to masks and gloves and gowns, because there are services, as Nancy said a moment ago, that are essential, are almost patient touching or drug access availability, and there have to be compromises and there have to be solutions to get those to work appropriately. The next part would be to observe facility technique for screening of entering visitors and do not enter if concerned. Almost everyone these days has a sign-in or has a screening mechanism in place, and we endorse those. We're putting those in our own pharmacies on the same way. It's a very important part to do. And the last part of this is really that treating people with the professionalism and the discretion associated with, if someone is concerned, then they should have the right to not enter. And that's not meant to create a situation of anarchy. It's meant to be very protective of and guiding towards the individual that's confronted with that. And there's ways that you get around that. But I don't think any of us are in a point in time where we are in a mode to force, and we should not do that. And we should try to work and accommodate as best we possibly can. As Nancy said also, it's very clear that when this on-site staff is in there, they need to take care of their personal materials and keep them disinfected. Just wipe. Make sure that everything is clean and that it is within a safe place and that you are not transmitting from there. And then lastly, if you look to the right, always adhere to good respiratory hygiene, cough etiquette, and effective hand washing principles. Probably every one of us has learned more than we ever thought that we wanted to know, don't touch your face with your hands. We even give specific guidance that says when you have finished your exit with the director of nurses, wash your hands in the bathroom and the lobby and don't touch anything on the way out the door. Use a paper towel, do something like that so that you are not touching any surface until you get outside. So these considerations are what we have adopted towards what our clients really are looking for us to provide guidance for, and we think that they become ways that others can do this as well. So I'm now going to move to considerations for operations, and I am going to turn it over to Derek Sturgill.
Thank you, Gary. In addition to minimizing your risk within your facility, we'd also like to share a few additional steps and procedures that can be taken by your pharmacy provider to help support your own internal processes. To start, we all own infection control. Ensure that your vendors also have infection control processes established. Policies should be adopted based upon the CDC guidelines. Emergency kits and automated dispensing units. Considering your regulatory guidelines, partner with your vendors to explore unit dose versus an exchange option for emergency. Delivery procedures. As Nancy previously referenced on a suspected slide, your pharmacy vendor should consider a centralized drop-off location within your facility. Maintain compliance in facility processes and procedures, but coordination to a central location will limit exposure across multiple units. Communication or coordination are critical. Infusion, similar to e-kits, establish clear processes for tracking, returning, and cleaning of infusion pumps. And lastly, medication availability. Through stressful situations,
Okay, folks, we are having just a little bit of technical difficulty. Let's see if we can get Derek back in, or I'm not sure right
Nancy, why don't you go ahead and why don't you continue, Nancy, if you don't mind, with the consideration for operations?
Absolutely. Thank you for the opportunity. Again, what we want to do is assure that while we all understand we're focused on COVID-19, we all know that the mainstay of care, especially for the chronic care resident, is pharmaceuticals. So what we want to do is ensure that refills are being requested at least 72 hours in advance. And what we've all been able to do with some type of ease of regulations is that things like refill too soon, some authorizations have been eliminated by many of the plans, especially for seniors, that allow us to go ahead and provide services even a little early if you're planning to modify your staff or don't have the resources. Additionally, your pharmacy may have an electronic fill system, a calendar fill system, or an automated fill system using barcode, software, or even the telephone. In addition to that, pharmacies also cleaning and disinfecting. And in cases where we believe we have had one of our staff members in an infected facility or one that has a positive case of COVID, we are having professionals come in and deep clean our pharmacies to assure that we are limiting the spread of that to the rest of our employees who are essential in continuing to provide you with that mainstay of long-term care, pharmaceuticals. Right now, our supply is plentiful. We do not foresee any drug shortages in the near future, and we will be monitoring that situation throughout the entire event. So rely on pharmacy to assure that we have the processes in place to prevent infection while continuing business as usual for all of the long-term care needs that your residents have.
Thank you, Nancy. I think Derek is back. So Derek, you want to talk a little bit about the human resources considerations?
I can, and I apologize. The call dropped on me right in the middle of the conversation, so thank you, Nancy. Another critical component of your success will be fostered through collaboration with your human resource partners. Our teams must understand that we all have a part to play in limiting the spread of the virus, and all colleagues need to embrace the solution. Engaging your HR business partners can help to establish a clear sense of purpose and alignment open lines of communication and concern, and offer opportunities for recognition of leadership through this very difficult situation. Once again, thank you, and I apologize for the call drop, Gary.
I believe that you're going to do human resources, or did you just go through that slide?
That was that slide, Gary.
Okay, thank you. So we're now going to segue into best practices for long-term care facilities and changes in the survey process. At this point in time, I am going to turn it back over to Nancy.
Thanks again, Gary. And be assured that pharmacies have looked at Nursing Home Compare, and we have looked at our customers, and so should you, look at your own history for the past 3 years for infection control deficiencies. Many of the management staff in facilities across the country have not been in that facility for 3 years, and it's pretty easy to determine if you think you're going to be a targeted facility for an infection control survey, which is where CMS, of course, is focused, especially after the events that happened in Washington State. However, if you have a suspected or confirmed case of COVID-19, and of course we're losing that word presumptive right now, make sure that you notify your pharmacy contact as soon as you know or learn of a suspected or a confirmed case of COVID. As Derek stated, it's going to change the way the pharmacy interacts and supports you and kicks in different processes for the pharmacy to deliver that pharmaceutical care. When calling the pharmacy, ask to speak with your pharmacy contact, and if they're unavailable, ask for the pharmacy manager, the pharmacist in charge, or a pharmacist. During urgent communications, I've always encouraged facility staff to communicate professional to professional. Do not leave your message in the hands of a busy pharmacy technician. Don't forget to notify all of your vendors when you have a suspected case, and especially when that case becomes confirmed. I can tell you that over the past weekend, for example, we were notified of suspected cases, but it was very difficult for us to discover whether the case was positive or the test came back negative. You may rejoice when one of your tests come back negative, but don't forget to notify the pharmacy so that we could put back into place the normal, usual, customary processes for your facilities. And if our facilities are ever declared safe, and I assume that that may take several weeks or even months, and it might even be geographically that facilities are determined to be safe, allow the pharmacy to know that as well so that we can go back to usual and customary services. During this time, and almost every day, really, you have to communicate your census daily to the pharmacy so that we can track your residents both in and out of the facility. Once a positive case is confirmed, the pharmacy will assist you to identify all of the pharmacy staff and couriers that have been in your building for the past 14 days so that not only you, but we can implement vector tracking and put into place our quarantine protocols if necessary. When a positive case is determined, the pharmacy should begin to leave your delivery at the door, keeping a proper social distance as a witness to your staff receiving that delivery, and ask the name of the person who is receiving it and allow the driver or courier to record their name. Do not ask during this period of a positive case that the nurse would sign a piece of paper, for example, that would be offered to the driver. During periods of active cases, the pharmacy should not be accepting any returns back to the pharmacy, and that would include any medications and or devices. And don't forget, ask your pharmacy important questions as to how will emergency kits be managed? How should hard copy prescriptions be sent to the pharmacy? And discuss any new services that require your support, or that you may ask the pharmacy of any service that might be suspended temporarily. As I said before, pharmaceuticals are the mainstay of care, and with strong communication and an effective plan in place, pharmaceutical care can continue no matter what the pandemic or the disaster may bring. So let me give you a real-life situation that we had yesterday, and we worked through it with our customer to assure that pharmaceutical care went on as planned. The facility had a positive case of COVID-19. They notified the pharmacy. However, this was a pharmacy that provided automated dispensing machines that released the doses at the medication pass, and there were 3 of these devices that hold large cassettes of drugs where they just come out in a package when the nurse requests for each med pass. Those cassettes needed to be replaced. So rather than say, oh, no visitors into the pharmacy, we can't do that, we both devised the protocols for protection and PPE and how this could be done safely. And in fact, since the technician who would have to go in and reload the machine was not accustomed to wearing full garb, we engaged our IV department to teach and train that technician to wear and to also to take off that garb before leaving the facility, how to change it in between machines and maneuvering about the facility without really affecting either the nursing staff and certainly not coming in contact with any of the residents in the building. So reaching out to the pharmacy, explaining what your situation is, what your regulation is, what your policy is, that collaboration can find an effective solution to assure uninterrupted, undisturbed pharmaceutical care processes. Next slide, Gary. Nice. What we want to do is make sure that if you have a positive case, that the pharmacy would send a single driver with no other stops to your facility to deliver the medications. During this time, as I said, send no medication, emergency kits or supplies or pumps back to the pharmacy until your event or your outbreak is declared over and your facility is safe. Arrange to have replenishment doses shipped to the facility for your emergency kit or your automated dispensing unit so that the nurses can put them in without having your residents exposed to pharmacy staff who may be younger, who may be asymptomatic, but may still shed the virus in your building. And while we know and recognize that this may be a burden to nursing staff to replenish some of these automated dispensing machines, again, collaboration and putting the greatest generation and their children first to prevent this infection just makes a lot of common sense. And what we find is when common sense prevails, everyone remains calm and there is no panic. Ask your pharmacy to ship additional locks for e-kits if needed. Use only disposable containers for medication, so you're not sending anything back or holding plastic containers or tackle boxes. Use emergency kit slips and fax them to the pharmacy without sending any paperwork. And then again, as soon as you are declared outbreak free, and it may be 24 hours after the outbreak, it may be 14 days after the outbreak, depending on what moving parts the CDC defines for us, we can then start to go ahead and have those things disinfected and sent back to the pharmacy where we will more likely than not disinfect them again. If you have a pharmacist that is required to destroy controlled substances in the state in which your facility is settled, store them in double lock security and try to extend the interval that the pharmacist has to come there. So if the pharmacist is coming every week, determine if they can come every 3 weeks or maybe once a month. We certainly have discovered that across the country, because of the inability to have a pharmacist witness drug disposal, that we are coming up with innovative processes like additional storage containers that lock, and even using things like Facebook or some type of web application where by video the pharmacist can witness two nurses destroying medications. So while we see, as with any era of crisis, innovation, and as Gary said, the technologies available to us will allow us to deliver that care thoughtfully while protecting your residents. We all will be working in this together, and as Gary often knows, I always quote Benjamin Franklin, if we do not hang separately, surely we will all hang together, and that will be what we need to do during this crisis. So thank you, Gary.
As everyone is aware, there are multiple additional resources that are out there to help guide what we do and how we think during this pandemic. Some of them are listed here for you to gain access to. We are fortunate at CVS Health to have an internal guide, which is on here as well, but the rest of them are certainly public. I guess I want to use this slide as a closure point before questions to come back to a slide that I showed a moment ago, which would be key aspects of a global response to a pandemic. As a person who has been a clinician his whole life, the amount of information out there is overwhelming. And one of the things that we have learned in this process is to centralize the tracking, monitoring, and implementation and education around what can be twice daily, 3 times daily updates from these organizations. When you do that and you stop everyone else from thinking that they have to be the source of all final knowledge relative to this, and you assign an accountability to this, it frees you up to really focus on the things that are important as it relates to your own accountability. And so I want to come back again and just close with this, that I know that there are multiple organizations represented, big, little, individual, facility, community, to behemoths of organizations, and the way that you actually engage the stakeholders within your own setting to manage information, flow of information that allows others to manage their accountability is probably one of the biggest lessons that we learned very quickly within Omnicare. And since we have done that, and there has been almost an assumption of accountability to be responsible for certain things, I think that we've gotten better at the way that we respond, and that we have become more appropriate and functioning at a higher quality than we were early, when we were all kind of reacting, probably like everybody else was reacting. So track your resources, assign individuals an accountability, and those of you that have responsibilities within that global area, it really is important for all of us to try to continue to focus on providing the care that we need to provide in the safest way that we possibly can. So with that, that is really the end of our structured presentation. We have about 15 minutes left for questions. There are literally pages of questions that have come in. I do want to say that if we don't get to the questions that are asked, that there will be, I believe, that we'll try to provide some further guidance on those. But for now, we're going to try to prioritize the questions as best we can. The first one I am going to send to Dr. Brennan. If you have not heard yet, before I turn it over to Troy, the Food and Drug Administration today during a press conference said that they had approved chloroquine and hydroxychloroquine for the treatment of coronavirus. So, Dr. Brennan, would you like to spend a few moments talking about that?
Well, I think this is sort of part and parcel of the administration's response. My understanding, and I didn't see the press conference itself, is that the president may have said that they approved it, and then the head of the FDA said, yes, they have approved evaluating it. Right now, there's been some suggestions from China and Korea based on, relatively uncontrolled studies that chloroquine and hydroxychloroquine, Plaquenil, which many of you know is used to treat malarial infection, is potentially useful against the virus. It's also had some utilization in rheumatoid arthritis. There was just, the French have been studying it pretty closely out of Marseille, and they've just published a paper within the last 18 hours or so that did show decreased viral shedding when you put somebody on Plaquenil plus a Z-Pak. And so that gives some sense that maybe there is something there. And I know that the French also have a trial underway. But I have to be careful about this because we just had a paper published in the New England Journal of Medicine looking at another set of medications that had been used in the past to treat HIV infection, which were thought to have had the same kind of reports about them that they could potentially be useful in the treatment of COVID-19. And the clinical trial, which had 100 people in each arm, showed absolutely no difference between the placebo group and the active treatment arm. So I'm relatively certain that the Food and Drug Administration is going to have to look at least at a trial or two before they'd be able to move on this product, which does have this tantalizing evidence about reducing viral shedding. But that's not the same thing as the information that we usually rely on. Quite frankly, I would encourage the FDA to follow the sort of standard scientific path rather than treating that as unnecessary bureaucracy because, we don't want to use medications that aren't useful. We'll see, and it's good that everybody's trying to move everything along as quickly as possible.
Thank you. Nancy, there's a couple of questions that are interrelated for you, please. The first part of the question is guidance on how ancillary providers who need to come into the building should be treated. And so it might be someone providing diabetic foot care, a dentist, an optometrist. Mm-hmm. The corollary question would be, what if the facility has to send someone out for a service such as dialysis? Can you kind of address both sides of that coin?
I will try. Thank you. It is a great question. Remember, any unnecessary medical treatment, like cutting toenails, for example, may be something that can be delayed. I know that yesterday, the CDC, for example, stated that unnecessary dental procedures like cleaning and maybe a replacement of a fill can be delayed and not to take on that type of caregiving. So what you need to do is have a tool to assess the medical necessity of the procedures. And if they do come in, those medical professionals certainly would want to wear the appropriate garb and take the hand washing protocols. Remember, the social distancing is used in those situations where personal protective equipment is not used. So while we all practice that in the public, caregivers, especially maybe a podiatrist that's coming in to treat a foot ulcer, would certainly put on all of the garb that they usually would. so that they are protected, and then dispose of it appropriately and wash hands in between patients and do all the things that our nurses do when they're going to touch mucous membrane or do wound care. I think that having the PPE available on the floors, if you have PPE, is appropriate. It is not obnoxious to ask these healthcare providers to bring their own PPE. One of the most, surprising area, not surprising, but one of the most care that we need to take is when we are providing nebulizer treatments to residents, and perhaps even Dr. Brennan can do this much better than I could. But remember that when providing a nebulizer, that will aerosolize a virus if the resident has one. And metered dose inhalers can often do the same job if a nebulizer is not required. So that is the time when your consultant pharmacist can help you with an appropriate metered dose inhaler if that person is capable of using one. And sometimes we do have to assist a resident who has a cognitive deficit to follow the directions with that. But as we take a look at minimizing the spread of bacteria, you sometimes have to think about dosage forms and inhalers and appropriate garbing when using a nebulizer. For example, full garb, eye protection, your mask, gown, and gloves is absolutely appropriate. And you would be treating this just as you would for any multi-resistant drug organism, where you would gown and immediately follow your protocols. The one thing that I can tell you is that if you are not doing infection control rounds twice a shift, you're probably missing the opportunity to teach and to reinforce your infection control program.
Thank you, Nancy. So the next question, Derek, I'd like you to go first, and then let's give Nancy a chance to breathe, and I'd like her to go from there. It's a very good and interesting question. Is there anything different about what you would do in a assisted living or senior living community than you would do in a skilled nursing facility relative to COVID-19 from an operations or from kind of a clinical perspective?
I'll answer from an operational perspective, Gary, and I'll turn it over to Nancy from a clinical perspective. From an operational perspective, I would say no. I would look at the considerations that were provided earlier, especially from a delivery procedure. Ensure that you're having a centralized location for delivery, limit the exposure into the facility itself. One of the things that is being discussed and looked at currently is the requirements in assisted living facilities around narcotic paperwork and the potential of exposure and carrying across multiple locations. So it is something that we're currently investigating. We're working with our legal team to understand what options we have around that. But obviously the regulatory requirements are a little more stringent in a senior living, assisted living customer than what it would be in a SNF environment. Nancy, I'll go over to you from a clinical perspective.
Sure. Thanks. One of the things that you have to consider is if your assisted living facility has a dementia unit. Most of those residents who are on that unit really are not capable at times in participating in their own infection control program. So washing hands after using the restroom, eating habits, those types of things need to be monitored a little more diligently than we usually do, especially if they wander and move off of the unit. The other thing that you might want to do is identify those residents who are at greatest risk. So while all seniors are at risk for developing a more serious case of COVID-19, and the older you are, the more serious it can be, you probably want to identify those residents who have pulmonary disease, have had asthma, have emphysema or COPD, those that are immune suppressed because they're taking anti-cancer agents or they're taking medications for rheumatoid arthritis or irritable bowel disease. Again, if you're unsure if a medication causes immunosuppression, you want to call your consultant pharmacist and ask those questions. You can also call the pharmacy and ask those questions. One of the other things that you can do is identify everyone who is taking an oral steroid and recognize the fact that the CDC believes that this virus will go ahead and replicate faster when someone is using oral prednisone or a Medrol dose pack. Those are the types of things that you can consult with the physician to determine if there is alternative treatment that can be used and if that steroid is absolutely necessary.
Thank you. Troy, there are numerous questions that are coming in relative to symptom management, prophylaxis of symptoms, supplements, OTCs. Can you address whether there's a standard regimen that one would use in an individual that is either presumed or with the COVID virus confirmed?
Not really, no. There's not. The treatment in the hospital is basically sort of provision of oxygen, and there's been a lot of discussion about a lot of different kinds of things that people have been trying at home, none of which have much support behind them. There's an ongoing discussion, which I can't say I've done any research on, but nonetheless not unbelievable, that there may be an association between use of nonsteroidals and worsening of disease. You know, it's a complex disease, and the way people are getting really sick and dying is, you know, a tremendous sort of immunological reaction, especially in the lungs, and development of acute respiratory distress syndrome. And as you know, ARDS is something that really only occurs in older people. Kids don't get ARDS, and so although originally we thought there weren't any children getting infected at all, there was just a report in the New England Journal yesterday about 10% of kids who they tested actually had signs of infection. And some kids with other medical illnesses actually did poorly. But by and large, it's a disease of adults, and it's a disease that is, when it gets really bad, is troubled by ARDS and some cardiomyopathy type symptoms as well. So, that's why we're thinking how shall we say, specific interaction with the immune system could turn some things off or turn some things on that could either help or hurt. But we don't have much information on that right now, unfortunately.
Thank you, Dr. Brennan, Derek, and Nancy. We have reached our time for questions, and I am now turning it back over to Jim.
Well, thank you very much, Dr. Irwin. We appreciate it. And we do hope everyone has enjoyed this presentation. We'd like to give our special thanks to Troy and Gary, Nancy, and Derek for some great perspective and advice for dealing with this novel coronavirus crisis. A special note that our environment and exhibit hall will remain open for a little while for your perusing pleasure. And we'd like to thank Omnicare again for its support in presenting this online expo presentation. You can find it archived, as you see on the screen, online for the next 12 months at mcknights.com/2020expo. Thank you again for tuning in. Please do visit the exhibit hall before you leave today. For McKnights, this is Jim Berkland wishing you all fearlessness, tenacity, and good health during these challenging times. We'll see you next time.